Thank you. Hello, everyone. My name is Mia Song. Thank you for the lovely introduction. I am a physiatrist here at Rothman, and like Casey said, I do non-operative spine and some general sports rehabilitative care here. Please let me know if you can't hear me or if my slides aren't advancing. Sometimes I have technical difficulties. All right, so today I'm going to be talking about low back pain, and let me advance my slide. This is exactly what okay, so did my slide advance? I just want to make sure.
Yeah.
Okay, great. So just an overview of what I'm going to talk about today. We're just going to review quick anatomy, what we're talking about when someone comes in with a back or spine issue. I'll go over some of the more common causes of low back pain that I see here at Rothman. And then I'm going to go into what happens when you actually come in for an office visit to be seen by me or one of my colleagues. And then what diagnosing pathology entails, and then different treatment options that we offer for back pain. So when we're talking about the spine, these are the major regions. There's a cervical region of the spine, thoracic, the lumbar spine, and then there's a sacrum and coccyx, and they're here labeled in different color coordinated regions. When people come in typically for low back pain, we focus on the lumbar spine, which is the 5 kind of the pink segments in the low back that sit between your ribs and your pelvis. Sometimes patients will come in for low back, but it may be in other areas like the sacrum or sacroiliac joints, maybe their hip. Sometimes it can go up into the thoracic spine. So we keep all that in mind. But generally, this is kind of, I guess, like the outline or map of where we're trying to localize patients' issues and symptoms when they first come in. Not to get too much into the nitty-gritty, but when we look at the spine itself, there are the lumbar vertebrae or the bones that kind of stack on top of each other and make up the spine. And in between, kind of on the right side of this picture, in between the bones and the gray color are your discs, and they help cushion and support your spine, especially in different activities and movements. And up top on the top right corner, there's just a cross section of what a disc might look like. There's also small joints in between these segments or the vertebrae of the spine called facet joints. And then, of course, moving on to my next slide, there are a lot of different muscles, ligaments, fascial planes that go over in that region, as well as different nerves that come out. I'm not going to get too much into the details of this, but as you can see here, I guess the point I'm trying to illustrate is that there's a lot of different structures in this region that can be potential pain generators. So some of the more common causes of back pain, this is kind of a long list, but what I see a lot of, and I'll go into what each one more specifically means. Number one is lumbar myofascial dysfunction. And what I mean by that is a lot of the different layers, I'm gonna go back one slide, different layers of muscles and tissues on the left-hand side sometimes become dysfunctional, and that itself can cause a lot of pain. Sometimes I see discogenic pain, meaning coming from the disc itself. Sometimes I see lumbar radiculopathy, and I'll go into further detail in the coming slides about what each of these mean. Lumbar facet arthropathy, or really like arthritis in the spine. Sometimes I see lumbar stenosis. I do see compression fractures here in the spine, as well as patients who sometimes come in with scoliosis. Sometimes I'll get patients who come in for low back pain, and their pain might not be coming from the spine or that region itself. Some other causes of pain in this region can include things like an infection, sometimes cancer or malignancy. Pain can be referred from the hip itself, or kind of like, you know, adjacent to the spine, but not quite the spine itself. Sometimes patients can have fibromyalgia that can also cause back pain. And then there's a whole host of other issues that are non-spine related, not some of these that I've mentioned, that can cause referred pain in that region as well. Really depends on how your symptoms present, and then, you know, getting a good examination. But this is just kind of an overview of just the more common causes. So let's get into what each of these actually mean. Lumbar myofascial dysfunction, like I said, it's a dysfunction in some of the muscles and fascial planes that cover the lumbar region. There are multiple layers of muscles that make up your back muscles and your core that kind of extend all the way around your spine. And sometimes it can just be dysfunctional, meaning it doesn't relax when the muscles need to relax and maybe stays in what we call a hypertonic state. And the way I like to describe that to patients sometimes is, let's say you're holding like a 10-pound dumbbell for 30 seconds. You're going to feel it, but it's not terribly, uncomfortable. But imagine you're doing that now for like a month without taking a break. It's going to be painful. And sometimes for one reason or another, muscles kind of do that. And that can be a cause or a source of pain. Discogenic pain. Discogenic pain, meaning that the pain is actually coming from the disc itself. So the best way, I think, is to maybe go to this picture here. You can see in between the vertebrae or the bones, you have the little gray discs that cushion in between. And sometimes there can be a disc rupture or a tear in the disc or a disc herniation like the one shown in this picture, and that can be painful itself. Sometimes I see this after maybe an injury where someone was lifting something really heavy and felt a sudden like pop in their back or something like that. And usually patients will say it's very painful, like sitting or driving, or when you cough, sneeze, or like laugh too hard even. Generally, patients with disc pain feel better when they're standing, moving around, or walking around. And they'll say it's weird. Activity makes it better, and that's pretty common and typical for disc pain. Lumbar radiculopathy is when a lumbar spinal nerve has an irritation or impingement, meaning that it's kind of pinched. And so it's what we think of as a pinched nerve. Those lumbar spinal nerves come out of your spine and then travel all the way down your leg, kind of like in this picture. And sometimes that's what people will come in and refer to as sciatica. I don't love the term sciatica because it's actually a misnomer. It's not your sciatic nerve that's being pinched or affected, and that's actually far less common. It's usually a lumbar spinal nerve that's being pinched and causing that shooting pain that runs down your leg. Sometimes this can also present as numbness, tingling, burning that also travels down your leg. Sometimes I've even heard it feels like fuzzy or ants crawling. There's a lot of different ways it can present, but in general, that's what we mean when we see someone with lumbar radiculopathy. Lumbar facet arthropathy is just kind of a fancy word for arthritis in the facet joints. The facet joints are like little knuckle joints in your spine, and the arrows here kind of point to it, but maybe a little bit hard to visualize, but they're little kind of like knuckle joints that articulate and move as you move around using your back, doing your normal day-to-day activities. And a lot of times people will develop facet joint arthritis as part of the normal aging, wear and tear degenerative process. And I can see this in patients as early as maybe early 30s. And for a lot of people, it's not painful or symptomatic. It's just part of normal, age-related wear and tear. But at some point, it can become a source of pain for some people in their low back. And generally, it is what we call axial pain, or meaning pain that's just in your back. Unlike radiculopathy or a pinched nerve, you don't normally get a lot of pain shooting down into your leg or anything like that. And it usually is worse with kind of like those twisting motions where those joints might be rubbing up against each other. And for that reason, patients might feel a little bit stiff or just feel like they have decreased range of motion coming from their low back. Lumbar stenosis. So the term stenosis just means a narrowing of a space, and you can have stenosis anywhere, like in any structure of your body. But when we talk about lumbar spinal stenosis, we're referring to the openings where nerves and other structures travel through. And so the best way I probably want to describe in this picture, there's that opening in that middle of that structure, which is in between your vertebrae, like the posterior segments and the disc. And on the right side, it shows stenosis, which is narrowing of that space. And you can see how much smaller that space is. You can get stenosis from a lot of different reasons or causes. And it could be things like disc bulging, disc wear and tear, maybe some arthritis, and all of that combined together can cause crowding or stenosis of that region. And then what happens is instead of an opening being that big, it becomes a little bit tighter, and it causes a lot of pressure on the structures inside of it, which include your nerves. And sometimes that can cause pain in your back, running down your legs, and can sometimes be worse with activity or walking around, and usually subsides when you sit and are resting. Sometimes I see patients with vertebral compression fractures, and that's when the vertebral body or the vertebrae has a fracture and it starts compressing. And you can see here, this picture, very exaggerated, but this, there's a little fracture and it causes that deformity in that vertebral body that we can see. Sometimes this happens as a result of a trauma or a fall, especially in the winter months with particularly bad weather like snow or sleet. Patients, who have falls and develop severe back pain definitely want to make sure that we rule out or evaluate them for compression fractures. Sometimes patients can develop compression fractures without falling or anything, and usually, in most cases, not all, but most cases, it's because of an underlying osteoporosis or weakening of your bones and decreased bone density. In these cases, in both, traumatic or osteoporotic fractures, pain is usually located right in your back, right where that fracture is. Sometimes it can cause referred pain going up and down your back, but patients will usually come in and say, I had a fall, landed either on my back or landed on my bottom, and now I have this very severe pain that's just right in the middle of my back. And so in those cases, we definitely want to make sure that we screen for any fractures. And then lastly here, I briefly mentioned scoliosis because this is something I do see. Scoliosis refers to a curvature of the spine. There is normal curvature of the spine, and then there's abnormal curvature, and scoliosis refers to the abnormal curvature of spine that we don't normally see. And there's a lot of different types of scoliosis and different causes of scoliosis. Pictured here in this slide is a adolescent, and a lot of times I'll see idiopathic juvenile scoliosis, meaning scoliosis that happens in children or adolescents as they're growing, develop this curvature. Sometimes I'll see scoliosis in patients who are much older, who maybe didn't have scoliosis as a child, but through degenerative changes and wear and tear in the spine, you can develop what's called degenerative scoliosis. And so that is also could be another cause for some back pain or mid back pain or even upper back pain. So with all of these things, now when should you go to the doctor's office? Well, it can be for a lot of different reasons. If you're developing or notice that you have new back pain symptoms that you didn't have before, or if you've had back pain before and it's flared up, or you're developing new symptoms you didn't have before, whether it's in your back or sometimes down your leg. Perhaps there's a recent or new injury that's affecting your back. And then I also do sometimes see patients who've had lumbar spine surgery in the past and then are developing new symptoms that they didn't have before. Or even if you had similar symptoms that you had before surgery, definitely helpful to see a physician for that. What happens when you come in for your office visit? It starts with taking a really good history. And these are some of the questions I like to ask. Number one, where exactly is your pain? Is it in the middle of your back? Is it off to the left or right side? Does it go down your leg? What seems to make it worse or better? For instance, is it worse when you're standing or driving in a car or trying to commute to work? Do you feel better when you're moving around or lying flat on your back? I always ask about other things like weakness in your legs or numbness down your legs. And I also ask about loss of bowel or bladder control. And sometimes patients will look at me funny, and that's because sometimes when there's significant issues in the lumbar spine causing nerve damage or nerve injury in that region, we can see things like weakness in your legs, like a foot drop, or sometimes we see people with bowel bladder issues. And it's because those nerves at the base of your lumbar spine also help control how you hold in your bowel and bladder. It's also helpful for me to know what you've tried so far for your symptoms, whether it's medications, over the counter, Advil, Tylenol. Have you tried any stretches or exercises or activities? And how did that work out for you? Gives me a better idea of what's going on and identifying what your pain generator is, because there are so many causes of back pain that can kind of present similarly at times. I also ask about prior medical and surgical history, which is very important to know, and your list of current medications as well for any other medical conditions that you have. We perform a thorough physical exam, which involves or starts with a neurological and musculoskeletal exam, where I may check the strength in your back and your legs, sensation, as well as some reflexes. I always check to see how patients are walking the minute they walk in the room or move around in the room, and it gives me an idea as well of where your pain might be coming from. Sometimes I'll check range of motion in your lumbar spine, or in your legs and hips, depending on where your issue or symptoms are. And then sometimes I'll do what's called provocative exam maneuvers. And they're just specific exam maneuvers that'll help me localize or identify where your pain might be coming from. It might involve me lifting and moving your legs around, or asking you to, turn and twist certain ways. And the idea is that that'll help me kind of pinpoint where exactly I think your pain's coming from. Sometimes diagnostic tests are necessary. Usually starts with an X-ray to rule out major things like a fracture or anything else unusual that we may see. On the hand side of this picture is an X-ray of your lumbar spine. I'm not going to go through all the different structures there, but that's what we would look at. And I do like to go over pictures in person with patients to kind of describe and show what's going on. I'm a very visual person, and I think that's helpful. Sometimes we'll order more advanced imaging like an MRI or CT scan if we think that that's going to be helpful or necessary. And then other testing includes things like electrodiagnostic studies, which are also called EMG or nerve conduction studies, or NCS. That's more informally called a nerve test. It looks at the nerves that are in your legs and you're coming out of your spine from the lumbar region. And it can give us a great idea of, it's helpful for patients who are having certain symptoms where we're suspecting either a pinched nerve coming from your back or other nerve problems, to see if there's any other signs of nerve injury. And sometimes I'll order labs just to make sure that there's no inflammation or infection or other things that might be contributing to the symptoms that patients are experiencing. And lastly, now I'm going into treatment options. It ranges on a spectrum, starting with more conservative treatment options and then all the way to surgery kind of on the other end of that spectrum. It starts with physical therapy, different modalities. There are other treatment options also that could be helpful that I'll get into. Medications, interventional procedures, and then, like I said, surgery. So when I prescribe physical therapy, there are a lot of goals involved with that. And this is kind of a general, broad, overview of what my goals are for therapy. And it might be different depending on what your specific pain generator might be. But generally, the goals of therapy are to help limit your pain or decrease your pain while maximizing your function so that you're able to do your day-to-day life or job or whatever it is. And also to help prevent a new injury or progression or recurrence of this issue in the future. With that, the goal is to help achieve lumbar stabilization or stabilizing your lumbar spine, and include some gentle range of motion if you have any restrictions. And then I also always ask physical therapists to assess patients for posture, biomechanics, and also an ergonomic evaluation. Whether you work a desk job or have a physical job, you're moving around all day, or if you are, at home taking care of your grandchildren and need to pick them up, finding ways to do things like that safely without aggravating what you currently have going on is really important so that you can do what you need to in your day-to-day. And that's something that physical therapists can help evaluate for and help work on with you. And then I always say the most important bit of going to physical therapy is a home exercise program that they give you. It's like homework that they give you, and it's meant to be done every day, maybe 10, 15 minutes, once or twice a day. Depends on what you're doing in therapy and how much you're tolerating. And that's really the most important bit. I always say it's like going to the gym. Like, you don't go once and then come out with like a six pack or super strong, even though that would be pretty awesome. It just takes a little bit of time showing up for yourself every day to make these small changes to help you feel better and get stronger. The initial evaluation when you see physical therapy for the first time is going to be probably like an hour-long evaluation session where they may take some measurements or see how much you can do. And then that allows the therapist to come up with a treatment plan that's specifically made for you and to be modified as you progress through your physical therapy course. Patients always ask, well, how often or how much am I going to go? I generally say it's 4 to 6 weeks, twice a week, but in honesty, I leave it kind of open between the therapist and the patient because it can be time consuming, and whatever works for your schedule is the most important bit for you to be able to actually do. I say in general, it takes about a month to really understand what you're doing in therapy, and then maybe another month after that to feel like noticeable changes or differences. And just kind of on a more personal note, I'll say I'm in physical therapy right now for my own back issues. And it's not my first time go around with physical therapy, but it works. And it's just something I have to show up and do for myself every day. I'll say I'm not the most compliant patient myself, but I'll sneak into exam rooms in between, like on my lunch break, to do some of my exercises. So it does help. Now I say they're method actors and more like a method patient. So I understand kind of how this process, at least with therapy, goes. And I'm always happy to talk to patients about that. When I say modalities, they're additional tools that can be helpful in mitigating your pain while you're doing therapy or other activities throughout your day. It can include things like heat or hot or cold compresses, a TENS unit, which is kind of like that little device that has electrodes that stick onto your skin, provides a small electrical stimulation to help achieve some pain relief. It can be ordered through insurance. You can try it in physical therapy to see if it's helpful, or sometimes patients can order one like online themselves through like Amazon or something else like that. And then lumbar orthosis, or just a fancy word for a back brace. There's certain indications for back bracing. I don't love it for every patient. And in general, I don't love back braces for a lot of like more common issues that I see. And it's because patients can end up becoming dependent on it, and it can lead to muscle atrophy or weakening of your core muscles. And in the long run, that actually does you a disservice, where with core weakening, you're putting a lot more pressure on your spine itself. And that itself can progress or worsen maybe some of the degenerative or arthritic changes that we see in the spine. One case where I definitely think back bracing is necessary is if patients had like an acute compression fracture. But in some other cases, it'll be like a case by case. Additional treatment options includes things like acupuncture. It's one of the few things shown with research to be helpful for certain types of back pain. Osteopathic manipulative medicine, and it's kind of hard to show you without showing you in person what that means, but this is kind of like a picture on the right. I like to think of it as somewhere in between physical therapy and massage therapy and chiropractors. There are maneuvers that you can do to like crack joints, but there's a lot of soft tissue techniques to help engage different muscles and joints to help achieve better range of motion, more function, and help muscles kind of calm down as well as get stronger. And I think it's a great alternative. Usually this is performed by osteopathic physicians. I am an osteopathic physician myself, and I do have training in osteopathic manipulative medicine, but unfortunately it's not something I practice actively anymore. However, there are, I have colleagues here at Rothman who still do this, and it's a great alternative or additional treatment option to other things for certain patients. Sometimes patients get really good relief with chiropractors, and patients will get this question a lot, like, do I recommend it? I think if it's been helpful, then definitely it's a great additional treatment. If you go a couple of times and you haven't noticed too much difference, then generally I'll say maybe we'll try a few other things and see if it works out better. And then massage therapy, sometimes for more soft tissue or myofascial conditions, can also be helpful. Medications. This is by no means a comprehensive list, but just more of the more common medications that I tend to use for the common causes of back pain that I talked about earlier. And it starts with things like anti-inflammatories, whether it's NSAIDs like ibuprofen or naproxen. Sometimes steroids are helpful for short term. Muscle relaxers can be helpful as well as neuropathic pain medications. And those are things like gabapentin or pregabalin. Neuropathic pain meds, I always tell patients they're not addictive. It's not a narcotic or an opioid. It is best when taken consistently every day. And it can help for, when I say neuropathic pain, like nerve pain. And it's like that burning, maybe sharp pins and needles or shooting pain. And I like to think of it as like kind of turning down the volume on any type of like nerve noise or irritation that you might be feeling. And then along those lines, tricyclic antidepressants can also help with neuropathic pain. And those include things like amitriptyline or nortriptyline. For some patients who don't get relief with the other treatment options mentioned before, we can consider things like interventional procedures. This includes things like epidural steroid injections, sometimes radiofrequency nerve ablations. There's an Intrastep procedure, which is a basivertebral neuroablation. Some patients benefit from spinal cord stimulators, and then spinal augmentations mentioned here, which is also called vertebroplasty or kyphoplasty, and that's specifically just for patients with compression fractures. Each of these procedures is performed for very different diagnoses or underlying causes of your pain. And so it's hard to say whether someone is a candidate for this or whether they're not until we fully evaluate you and try to really figure out where your pain is coming from. A lot of times patients will have, imaging or other studies that show that you may have like arthritis in your back or some stenosis. But if it's not the cause or root of your pain or your pain generator, then doing certain procedures where may be helpful for other people might not always be the best option for you. And that's where having that discussion and being evaluated by a physician in person and getting a lot of background information is really helpful, because I definitely would love to help you achieve better function and minimize your pain, but I also want to do things safely, and I always want to make the right recommendations for patients where I think that you'll have the possibility or potential to have good results from an injection or a procedure, rather than just, saying, oh yeah, let's try that. If I don't think it's going to help much, I'll be very honest and let you know. And then I kind of go into why that might be the case. And so hard for me to go into every single procedure here. There are other procedures that we do, but it really depends on where your pain is coming from. Along with interventional procedures, I always go through risks and benefits of each procedure. And that's something I also have a very open conversation with patients about before the procedure. Make sure that you're able to make a fully well-informed decision, and then go from there. And then sometimes I'll send people to see one of our surgical colleagues, would be one of our spine surgeons. And sometimes patients ask, when is it time to see a surgeon? Could be patients who have symptoms that are ongoing, that are refractory to other treatment options, meaning it's just not getting better with some of these other things that you've tried, like therapy, medications, injections. Sometimes patients who have signs of nerve damage, they might be good candidates to see a surgeon so that you can have, be treated appropriately to potentially reverse or avoid permanent nerve damage. And that can look like either weakness in your legs or loss of bowel bladder control, which is again why we're so obsessed with asking about that. Because if patients are having new weakness, maybe new numbness, or especially like the bowel bladder issues, that may be reasons to see a surgeon. Generally, when I talk about bowel bladder issues, it's just as a sidebar. I mean, if you are experiencing complete loss of control, like you're having accidents going and you're not even realizing it's happening at the time. Like, let's say you were sitting down eating breakfast and you got up and you realized you had wet yourself and that's just not normal for you, that would be something concerning. Sometimes patients will experience like, I can't get to the bathroom on time or else I'll have an accident. That's a little bit different. But if you're not feeling it at all and you're not controlling it, that's kind of what we're trying to make sure you're not experiencing. But certainly that's part of the history that I try to tease out when I get to meet and get to know patients. And I think that is my last slide. I hope I didn't go through this too fast. A lot of information, a lot more goes into each office visit for each patient, trying to figure out what your underlying pain generator and issues are, and then coming up with a treatment plan that's right for each patient. Again, it takes time to get to know people, and definitely want to make sure that we try the best to figure out what is causing your symptoms and making sure we make best recommendations for your case. But anyway, I'm happy to answer any questions right now.
Yeah. Thank you, Dr. Song. This is a lot of good information, and I think we all can take home something from here. There are a couple questions. Before I do that, I just want to remind everybody of this VIP line. It's just a little bit more access than the 1-800 line. The phone number is 610-480-6584. Again, 610-480-6584. One of the questions is, how many epidurals is safe to have?
That's a great question. Generally, I would say, generally speaking, for most people, about 3 or 4 in a calendar year or 12-month period. And that's because a lot of steroids over, repeated epidural injections have a lot of other side effects. Steroids themselves can cause your blood sugar to temporarily increase. It can affect your adrenal glands in the long run. It can also worsen your bone health. And so it's reasonable to try, 1 or 2. And then if you get good relief after that, I prefer to try to hold things out longer. Most patients, I'll say, like on average, who do get repeat injections, maybe I'll see them like once or twice a year, and it's for the same exact pain. If it's new pain in between the injections, is something I definitely would like to know about.
Yeah. Somebody asked which offices you're out of. You are out of Media, Glen Mills, South Philadelphia, and Center City. You rotate offices. Do you perform the mild procedure?
I do not. I don't do the mild procedure, and to be honest, I am like fairly new here. I would have to ask to see if I have colleagues here who do perform that. I don't know the answer to that, to be honest.
Yeah, I actually haven't heard that. So,
Mhm.
let's see. There are a lot of questions coming in. We might not be able to get to them all. So, let's see. Sorry. I'm just trying to go through this. What about sacroilitis? Could you touch on that?
Yeah. Oh gosh, I can't believe I didn't mention that in my talk. I do see that. So sacroiliitis or SI joint dysfunction is the sacroiliac joint is a small joint in between your sacrum and your ilia or your pelvis. And sometimes that itself can be a pain source. I will say it is pretty rare to have true sacroiliitis or sacroiliac joint dysfunction and pain, but that's definitely something I screen for in patients who come with low back pain kind of in that area, because it can kind of overlap and kind of come in masking as lumbar spine pain. So yes, absolutely, that is something I do evaluate for in the office. I do see patients with that quite a bit. And I do also do like sacroiliac joint injections, and in addition to like hip injections and things like that are not, lumbar spine related. But yeah, sometimes that can kind of mask in coming in as like low back pain. And that's where a lot of the provocative exam maneuvers and actually being seen by a physician in person is really helpful.
Yes, agreed. Which of the Which of the compression of the discs in between the vertebrae? Which of these is compression of the discs in between the vertebrae?
So that you may be referring to like disc, when a disc degenerates or has wear and tear, it starts getting a little bit flatter and can start bulging. And that itself isn't a diagnosis, but it can cause things like the stenosis or lumbar radiculopathy. And so that's something we see that can contribute to some of these other etiology of the spine. Sometimes, flattening or compression of that disc may be associated with like a, disc tear or an annular tear. And again, that itself may or may not be painful. And it really depends on where your symptoms are and kind of the whole like person evaluation.
Someone is asking, is osteopathic manipulative medicine and massage therapy covered by Medicare? Do you know that?
I believe so. Osteopathic manipulative medicine, I believe, is covered by Medicare and insurance. I'm not sure about massage therapy, to be honest. I've had a number of patients where it was covered by insurance, but I'll be honest, I don't remember if it was Medicare or like a different insurance provider.
Does any impairment in the lower spine cause numbness in hands and feet? What interventions are recommended?
So numbness in the feet can come from the lumbar spine. Numbness in the hands is not usually related to the lumbar spine. And numbness itself, either in the hands or feet, can be coming from the spine or it can be a different peripheral nerve issue. And again, that it really depends on where exactly the symptoms are and patient's history, and then doing a really good physical exam and evaluation in office is necessary to kind of get to the root of what's causing it. Because if it's coming from the spine, we can try to do things to treat that. But if it's coming from something else, like just an example, like diabetic neuropathy, then getting better control of your blood sugar can help with the numbness and tingling in your hands and feet. And that's just one example of why someone might be experiencing that. There's like dozens of reasons. And so hard to say just like generally, but definitely again, being evaluated would be really helpful.
Okay. There's quite a few people asking, is it safe to do the epidurals the rest of your life? Is there a limit, or at what point is surgery needed?
I'll be honest, I don't think there are good research studies on the lifetime limit of epidural steroid injections. And in general, I think the limitations have only been studied like in annual or year-long increments. I will say anecdotally, I do have patients who come in once or twice a year and they get an epidural, they feel great, and they get good enough pain relief to be able to go about their normal lives. I would say if you have the same exact pain that you've had for like a long time and epidurals worked well for you at one point, and then it kind of wears off and the same pain comes back, but then epidurals kind of stop giving you that same relief, then it might be, the next step might be to talk to a surgeon, because then that would be a case where your symptoms and pain are refractory to other treatment options, meaning what we've normally done for you isn't helping anymore, and maybe epidurals aren't the right way to go anymore.
Right. Yeah. And one of the things here at Rothman is we are very subspecialized. So Dr. Song works on the spine non-operatively, but she knows when it's time to pass it. If you do have to see a surgeon, we have spine surgeons that only work on the spine day in and day out. And so as a team, they can work together to get you to the next spot, should that be the case. I know Dr. Song has to go, so there are a lot more questions, and I apologize we couldn't get to them all, but I really appreciate everyone taking the time. Dr. Song, thank you for putting this together and speaking here. I think it was great information, and I did record this, so I will send this out in the next day or two, so everyone should have it. So I appreciate you again. Thank you for coming, and thank you, Dr. Song, and everybody have a great day.
Thank you so much. Have a good day.